Thanks very much indeed. And thank you very much to Professor von Braun and Professor Baumann for your invitation to these two academies. Friends and colleagues, delighted to be here to be talking essentially about cancer networks. Is that actually my first slide? I don't think it is. Yes, it is. There we are. We might first ask the question, how many quality-assured comprehensive cancer centers are there actually in Europe? And secondly, to ask, to what extent are those comprehensive cancer centers networked or engaged in binding outreach? And thirdly, to ask, how can we tell how effective those cancer networks are? My own program at OECI has now 92 centers in the accreditation program. We have more than 150 members of OECI, but only 92 are in the accreditation program for CCCs, and that, of course, does not include Germany, as we've just been describing. Christian, in a few moments, is going to talk about the 14 comprehensive cancer centers in Germany and the way they network. And as we've just heard, the plan and the objective of EU NetCCC is to incorporate 100 of those CCCs into a new network by 2028. It was already mentioned in passing the better outcomes of patients who are diagnosed and treated in CCCs. Often we assume that, but actually the evidence is hard to obtain because there are so many confounding factors. There are fairly good data in two studies in the United States, Pfister et al. And Wolfson et al. a few years ago, by looking at the risk-adjusted survival outcomes in hospitals that treat patients with cancer without information on cancer stage, looking at those patients treated in NCI cancer centers, veterans hospitals, and other categories of hospitals. And again, the survival benefit seems to be around a 10% advantage. There is a growing, well, a continuing debate really about how many patients and the percentages of patients in different member states who are treated or diagnosed in quality-assured centers or networks around those centers. And I actually think the OECI data actually is more optimistic than you mentioned, or if I may say that. It suggests that the range, okay, there's a huge range. In some member states, only 10% of patients are so treated. In other member states, as I shall show in a few slides, actually the rate is more like 90%. So very high in some of the Nordic countries, in Ireland, in the Netherlands. So the mean, actually, I mean, we know we're all aiming towards 90%, is probably around 40%, 45%. We need to look more carefully at this and get more data, but it's not quite as pessimistic as has been described. And we already had from Ravi a target of 60% in India to beat. So let's go forward for that target of 90%. I think around this table, we all know the definition of a comprehensive cancer center. We don't need to dwell on that. We've built on the findings and the experience of the NCI in the United States. The OECI follows a very similar definition. So does Deutsche Krebshilfe. So do the CRANE and EU NetCCC joint actions. So I won't dwell on that, except to emphasize, yes, the tripod of research, high quality care and education, and that research really needs in a CCC to be really deep and really broad. The breadth and the depth and the environment are absolutely crucial. Going back to a few stages, to a few joint actions that my colleague here, Tit, was very heavily involved in, the CanCon description of integrated cancer care, which also involved the description of what a comprehensive cancer network should be, covering the whole patient pathway and involving comprehensive cancer centers, smaller clinical cancer centers, research institutes, parts of general hospitals, and diagnostic units, whether they be private or public. This was a foundational document co-funded by the European Union in a joint action, and much has flowed from the findings of this report. So these are the challenges that we're facing. It's all about equalities or inequalities. How do we reach all cancer patients in a nation with quality-assured services? A subsidiary point is, I think we all admit that not all centers can do a huge amount of research. We should not expect that butter to be spread so thinly that there's complete equality around research, Therefore, the question is, how can those who do very high quality research, how do they disseminate that innovation to all centers within the network and nationally and internationally? Thirdly, how can clinical trials be equally accessible to all cancer patients in a network, in a local geography? And how can patients who need complex treatments be seamlessly and effectively transferred to other hospitals who have that specialism? And finally, how can data about patients securely be shared with all the necessary professionals and all the necessary institutions within the network? The answer to those questions, we submit, is effective cancer networks, local networks. And a few years ago, OECI published in Acta Oncologica a study of how to evaluate comprehensive cancer networks, and we reviewed the literature around the world and then did a comparison with a new set of OECI standards specifically for networks. We looked at more than 1,000 articles, but frankly, the literature, very specific literature, is very thin. Only 17 of those reported on evaluation methodologies and quality indicators for networks. We were happy to see that of our proposed 54 network standards in OECI, 32 of them had a significant equivalent within the literature, but there were some that were new. And obviously, as with comprehensive cancer centers, the methods of accreditation and evaluation involve surveys, questionnaires, self-assessment, a document review, but very importantly, and we cannot and we would not avoid this, a physical site visit. There is no substitution for observation going on site, seeing how cancer works in a center and in a network, actually going there, and it's quite a complicated business. From that paper, we deduced 8 basic quality principles for comprehensive cancer networks. And these mirror very largely the earlier work in CanCon and build on it. First of all, it's pretty obvious, isn't it? The governance of the network should be clear. The members of the network should be joined together and bound together in commitments, especially on the care pathway. Also on research, but the care pathway has to be absolutely clearly delineated across the network. That all comprehensive cancer networks should have at least one CCC present. Now that can be a challenge, but the CCC will noticeably be the hub for research, both clinical research and translational research. As I said, the patient pathways within the network should be clear, they should not be sporadic, they should not be random. Clinicians, patients should know where they're going, where they're going to be treated, and the next step for their treatment, even if that's in a different institution within the same network. The strategic research collaborations should be clear and should be promoted. The clinical guidelines, we don't mind whether they're NCCN, whether they're ESMO, whether they're NICE, but they should all be the same within the centers within that local network. That there should be a consistent approach to central registration of cancer patient data, and I can hardly ever say this, there should be IT interoperability, got through it, and data sharing for all the multidisciplinary teams. These are the fundamental 8 concepts and objectives for quality measurement of cancer networks. I would probably add 4 more, actually, if I was rewriting the paper. The first one would be there must be access to a molecular tumor board. Equal access for all patients diagnosed and treated within that network, whether that molecular tumor board is in the CCC or whether it's a regional molecular tumor board. Secondly, the question of surgical specialization. Alex will remember in the United Kingdom, when the first cancer networks were created in the late 90s, a massive amount of difficult negotiation between hospital chief executives, finance directors, etc. You know, liver cancer was only going to have resections in 2 centers or 1 center in the network. Pancreatic cancer was also only going to have resections in a center that did a certain number of resections per year, etc. A lot of difficult negotiation. And the network doesn't actually, it doesn't threaten the life of small cancer centers or cancer hospitals. It actually increases their sustainability by the value and the strength of the network. Thirdly, I think I think that the consensus generally is that comprehensive cancer networks should be pan-cancer. Yes, of course, there is a need for tumor-specific liaison throughout the network. But above and beyond that, there needs to be a central governance that is committed to all cancers and all research within the network. And finally, this kind of networking can take place in any health economy, an NHS health economy, and as I shall show in a few slides, also in hybrid economies, including the one that I'm mentioning here. The regional oncology network being delivered in the Netherlands is in such a semi-insured, semi-public network. It has grown up in the last few years. It's been a bottom-up approach. It now covers all of the Netherlands. Each one of those 8 networks has one CCC present at the hub, and it's probably true to say, therefore, that apart from very private medicine, 90% of cancer patients in the Netherlands are now treated in a quality-assured network. Secondly, where I now come from, have the pleasure of living in the island of Bornholm, there exists the National Comprehensive Cancer Network, the DCCC, which includes major nodes and comprehensive cancer centers, but also other general hospitals treating cancer. Many of those centers are within the OECI accreditation program. Finland has 5 regional centers, but it has a national cancer network called FICAN, which involves all the hospitals treating cancer in Finland. Again, you can probably say that 90% of cancer patients are diagnosed and treated in a quality-assured cancer network. And all those 5 centers are part of the OECI accreditation program. Finally, Ireland, which has 9 designated cancer centers or comprehensive cancer centers. Most of those are within the OECI program at the moment. And I checked this with a couple of the cancer center directors. They confirm, even taking into account private medicine, 90% of patients in Ireland, a population of 5.5 million, are treated in this quality-assured national network. And now, to give a German perspective, I hand over to my colleague Christian. Hand that over.
Yeah, thank you, Simon, for this introduction. And I was asked to give a brief glimpse of a German perspective. So, as many of you know here in the room, Germany has a very fragmented health system. To break this down to cancer, we have over 1,000 medical oncologists in private practice. And as you may appreciate from this chart, there's a significant proportion of patients, over 40% of patients receiving chemotherapy in private practice. And this contrasts with the situation in France, Italy, Spain, or the UK, and many other European countries. So in essence, in urban areas, there's a strong competition between different healthcare partners, and market forces can lead to disparities both in urban areas and in particular in rural areas. The German cancer architecture is really thought as a pyramid, and at the bottom of this pyramid are the organ cancer centers. There's over 2,000 of those in Germany, all certified by the German Cancer Society. So you have along side by side breast cancer center, colon cancer center, and so on and so forth. Luckily, most of them are grouped within clinical cancer centers, and there's over 160 in Germany, certified by the German Cancer Aid on an annual basis. They're multidisciplinary by nature and cross-entity, and these are really sort of the workforce of German oncology. And then on the top of the pyramid are the comprehensive cancer centers, and I'll tell you a little bit more about NCT and its particularities in just a moment. Among the CCCs, there's 14 centers in Germany, all designated and funded by the Deutsche Krebshilfe, and spread around the country. And this is really a large program that was started about 20 years ago, and Lex Egermont and Sir Alex Markham were among those that put this together with the Deutsche Krebshilfe in place back in the early 2000s. So the observations that we have in Germany is that on one hand, CCCs are connecting to form CCC consortia, meaning 2 university sites or 3 or even 4 sites making one CCC consortium. So that's one level of networks that are emerging. And if you now talk about these 14 designated CCCs, CCC consortia of the Deutsche Krebshilfe, these actually represent 26 university hospitals. Importantly to note is that a significant number of patients are diagnosed in these CCCs, but that only, I should say, amounts to roughly 20% of all newly diagnosed cancer patients in Germany. So in other words, over 80% of patients are diagnosed outside of CCCs. This number is expected to increase in next years due to a number of reasons, including an ongoing hospital reform, but that is a reality in Germany. And the other aspect is that German CCCs tend to be smaller in comparison, at least to the largest European centers. So what is the solution to that? The solution to that is to form networks on a regional basis, for instance, as CCC consortia, one way, or to form a new regional network with clinical cancer centers and medical oncologists in private practice and other physicians in private practice at a regional level. This is then obviously also connected to a national network, the CCC network of all 14 CCCs designated by the Deutsche Krebshilfe. And importantly, a new network of excellence formed called the NCT, headed by Michael Baumann, that is very significantly focused on early translation, clinical translation, meaning taking translational discoveries into early clinical trials. This is accompanied by another network called the German Cancer Consortium, or GKTK. So what we're talking about here in Germany is a network of networks. And that is obviously something that we're taking to international EU-wide connections, in particular with the OECI and some of the EU initiatives where we're trying to be supportive. So coming back now to the regional level, I just want to take 1 or 2 minutes to introduce to you a recent initiative funded by the Deutsche Krebshilfe that started just about a year ago, and that intends to strengthen these regional cancer networks. And they really work along the 8 principles that Simon introduced to you that were put forward by our colleagues from OECI. And the first thing is, among the governance issues, is to professionalize our organizational structure. So each of the CCCs within the network and the 26 university sites now employs outreach managers, because this is heavy communication to get this going in such a fragmented health system. And secondly, to develop best practices. So we started out with best practices in 5 important areas, and each of them is a really challenging field. Prevention and early detection, and defining the role of CCCs in this important arena, as we've already heard today. Second, patient engagement. Clinical trials, obviously a very important hallmark of CCCs. Quality assurance instruments, and IT interoperability, which was also one of the standards that Simon talked to. And just to give you a brief glimpse of what that actually means, patient engagement, for instance, we're building up an academy for education training of patient advocates to train them and give them the opportunity to discuss important aspects of coordinated cancer care and research. Second aspect is clinical trials. Enhancing regional access to molecular tumor boards is something that we're actively pursuing. And then, as a recruitment base, use the outreach, use the regional networks to build clinical trial networks and enhance the patient base for clinical trials, in particular for small molecular subtypes. So with this, one further, I hand over to Simon to summarize our talk. It's the last slide.
When we merged our slides, the OECI branding came up on all the German stuff as well. I do apologize to you and to all German colleagues present. This is not a bid for power, as I say. So, summarizing then the strengths, a SWOT analysis really of cancer networks in Europe, the network multidisciplinary teams that we have observed and and tested are generally good. There is consistency in the use of clinical guidelines. It is clear that in patient pathways, patients with complex needs are referred to the specialist centers, and the patient pathways are generally gaining in clarity. Weaknesses, still, I'm afraid, the dreaded data sharing and IT interoperability is a barrier, even within networks, even within the same region of the same member state. Very tough. Often there is a lack of a network-wide approach to clinical trials. The evidence seems to be that patients who rock up at the CCC get more of an access, a better access to clinical trials than those who turn up in the smaller general hospital in the rural areas. And also translational research is not yet well enough networked within these networks. Finally, there's a policy point here. No matter how good the networks are, if the member state does not reimburse high-cost drugs, then you might get equality, but you don't necessarily get quality. And I think that is a challenge within the weaknesses. And these networks do not happen by osmosis. They require a bit of funding. They require a secretariat. Otherwise, they simply won't work effectively. Opportunities, obviously, the data, much more data for outcomes research, the importance of the patient voice, the opportunity to deliver care closer to home where it's clinically appropriate. It sounds like a golf buggy. Must be the Pope. And the threats are the same threats affecting cancer networks as affecting the cancer generally. The workforce crisis, our aging population, many rising toxicities, the cost of cancer becoming unmanageable, and the question of competition that there is between hospitals in metropolitan areas particularly. So I hope that with cancer networks working effectively, we are moving from competition to collaboration. Thank you very much for your attention.